participants for continuing with the faculty development program. I know that most of you have gone through the foundation course recently, and congratulations for getting certified so soon. It was a very fast forward program. So now we are going to the second phase of the program, which will be mostly focusing on integration of modules recommended by CBME into the undergraduate medical education, which is relevant for palliative care. So first, we'll have a quick round of introduction of all the participants, and then we will hear from Dr. Rajagopal on why do we do this? Why are we bringing in people to do this? What was the vision behind this whole integration program? And then we have Dr. Kadambari from JIPMER, starting off with the formal training with making us understand a little bit about the principles of integration, because we talk a lot about integrating this into the undergraduate medical education, but we really don't understand the whole concept of integration per se. So we'll be hearing that also. So we'll start with a quick round of introduction. You can tell your name and which institution you are and which specialty you are in. I'll start calling the names which I can see on the screen. I think I can see Dr. Anup. Dr. Anup, can you unmute yourself and introduce and say your specialty and the institution you are from?
Good afternoon. Can you hear me?
Yes, we can.
I'm assistant professor in Department of Radiotherapy in SLBS Government Medical College near Chowk, Himachal Pradesh.
Thank you, Dr. Anup. Dr. Indira?
Namaskar. I'm an associate professor in radiotherapy department in Srinagar Medical College, Uttarakhand, BSc Medical College.
Thank you, ma'am, and welcome.
Okay, thanks.
Dr. Usha?
Good afternoon. I'm Dr. Usha Rani from Community Medicine Department, Associate Professor, Sri Siddhartha Medical College, Tumkur.
Welcome, Dr. Usha, and thank you. Dr. Hemant? Hi, sir. Can you unmute yourself and introduce?
Hello, are you getting my voice?
Yes, sir. Please.
Yeah, I'm Dr. Hemant Kumar Dutt. I'm Assistant Professor of Oncology from Government Medical College, Almora, that is in Uttarakhand.
Thank you, sir. Welcome to the program. Dr. Devashish?
Thank you. Yeah.
Hello.
Yes, Dr. Devashish, please.
I am Dr. Devashish Das, MO specialist from Calcutta Medical College, West Bengal, Department of Radiotherapy.
Welcome to the program, sir. Dr. Pranjal?
Good afternoon, all. I'm Dr. Pranjal Pratim from Jorhat Cancer Center, Assam Cancer Care Foundation, Assam. I am working in palliative medicine department as a medical officer.
Welcome, Dr. Pranjal, to the program. Dr. Tarangini?
Thank you very much.
Hello, I'm Dr. Tarangini Yadav. I'm currently working as senior resident in AIMS Bilaspur.
Thank you. Dr. Kalindi? Dr. Kalindi, can you unmute yourself and introduce? I think we'll come back to you, Doctor. Dr. Anjali?
Good afternoon, everyone. Hello, good afternoon, everyone. I'm Dr. Anjali Maheshwari. I'm working as an associate manager in ECHO India, and I welcome you all for the launch of this program.
Dr. Jalaj Gaur? Sir, are you in a position to unmute and talk? I think you are driving.
No issue, ma'am. Yeah. Hello, very good afternoon to all. Myself, Dr. Jalaj Gaur. I am assistant professor in Department of Radiation Oncology in Swami Ram Cancer Institute, Dr. Sushila Tiwari Medical College Institute in Haldwani, Uttarakhand.
Welcome, sir.
Yeah.
Dr. Priyanka?
Dr. Priyanka Thakur. I'm working as assistant professor in the Department of Radiotherapy, AIMS Bilaspur.
Welcome, ma'am. Dr. Suranjan.
Good afternoon, all. This is Dr. Suranjan Moitro. I am from Kolkata. Right now, I am working in Department of Radiotherapy as clinical tutor in R Rajagopal Medical College in Kolkata.
Welcome, sir. Dr. Kapil.
Hello, good afternoon. Myself, Dr. Kapil Mohan Pal. I am posted as Senior Resident in Department of Radiotherapy in SLBS Chowk, Mandi.
Welcome, Dr. Kapil. Dr. Shivani.
Hello, everyone. I'm Dr. Shivani. I'm Assistant Professor in the Department of Pharmacology at SLBS Medical College, Mandi.
Welcome, ma'am. Dr. Shatrupa.
I'm Dr. Satyanika, Doctor, Assistant Professor, Radiotherapy Department, Ajira Medical College.
Welcome, ma'am. Dr. Umesh. Dr. Umesh, you are muted. Can you unmute and speak?
Hello, myself Dr. Umesh from Siddhartha Medical College.
So you're from which department, sir?
Department of Pediatrics.
Welcome, welcome, sir. Dr. Neeladri. Sir, can you unmute yourself and talk?
Hello, myself Dr. Neeladri Rai, Assistant Professor, Department of Radiotherapy, Medical College and Hospital, Kolkata.
Welcome, sir. Dr. Maya.
Hello, myself Dr. Maya from Bhavnagar Medical College, and I'm Assistant Professor in anesthesiology.
Welcome, ma'am. Dr. Sumita.
Good afternoon, everyone. I am an anesthesiologist in Acharya Harihar Regional Cancer Center, Cuttack, and I am now the in charge of palliative care unit.
Welcome, ma'am. Welcome to the program, and nice to see you again to this into this program. Dr. Rupam.
Good afternoon to all. I'm Dr. Rupam Basti. I'm working as a professor in Department of Physiology at Sri Guru Ramdas Institute of Medical Sciences, Amritsar, Punjab.
Welcome, ma'am. Dr. Harishankar.
Thank you, ma'am.
Good afternoon, everyone. I am Dr. Harishankar Pandey. I am professor in pathology in Government Medical College, Haldwani, Uttarakhand.
Welcome, sir. Dr. Andrew.
Hello, I'm Dr. Andrew. I teach community medicine in Zoram Medical College.
Thank you, sir, and welcome to the program. Dr. Mrinal.
Good afternoon, ma'am. I'm Dr. Minal Dev Chaudhary from State Cancer Institute, Guwahati. I'm working right now as a medical officer in Pain and Palliative Department.
Welcome, sir. Welcome to the program.
Can you hear me?
Yes, we heard. Dr. Subrat Gupta. Dr. Subrat Gupta, are you there, sir? I think we lost him from the screen. Dr. Aditya
Hello.
Kumar. Yes, sir, please.
Hello. Yes, ma'am.
Please go ahead, sir. Can you introduce yourself, which department and which institution you are from?
Good afternoon, ma'am. I am Dr. Subrat Gupta. I am currently
Yes, sir,
I
please
am
go ahead.
working as an assistant professor in Department of Physical Medicine and Rehabilitation at Veer Chand Singh Garhwal, Government Institute of Medical Sciences, Srinagar, Garhwal.
Welcome, sir. Thank you so much. Dr. Suranjan Mitra. Dr. Suranjan, are you there?
Yes, ma'am, I'm there.
Can you just introduce? Oh, you already did your introduction, right?
Yeah,
Sorry,
ma'am.
sorry.
Already did.
Sorry. So now I think we have. Is there anyone who have not introduced yourself?
Hello,
Yes, sir. Please.
I am Dr. Indra Kumar, Additional Professor, College of Medical Science in Bilaspur.
Thank you so much, sir. Anyone else who have not introduced? If I missed someone.
Am I audible?
Good
Yes,
afternoon.
yes. Sorry.
Dr. Kalindi, you are muted.
Hello. Sir, am I audible?
Yes, sir. Please go ahead.
Yes, I am Dr. Bapadito. I work as in the Department of Radiotherapy in Medical College, Kolkata.
Welcome, sir. Dr. Kalindi, you are about
Thank
to
you.
introduce yourself.
Good afternoon. I am Dr. Kalindi. I am working as Assistant Professor in the Department of Radiotherapy at Shri Lal Bahadur Shastri Government Medical College, Mandi, Himachal Pradesh. Thank you.
Welcome, ma'am, to the program. I think we've covered everyone. Yes. Yes, sir. Over to you, sir.
Sri, one piece of information before I start. Is all the participants someone who has attended one of our courses, or are there others also?
So this batch, they have recently underwent the foundation course in palliative medicine. They completed 2 weeks back.
Okay. So hello, everybody. Good to see you all again. So the risk is that I might be repeating some things that I already have been drumming in on a session that I was with you previously on. So please forgive me for many repetitions. Like Sri said, very glad to have you all with us. We have a very important mission ahead of us. I was listening to the introductions and find that the vast majority of participants are oncologists and radiotherapists, vast majority. There is a sprinkling of very many specialties, others. There are a couple of palliative medicine people, couple of anesthesiologists, and at least one each a pharmacologist, physiologist, pediatrician, and physical medicine and rehabilitation. Apologies if I have left some specialist there, and one management person. This is perfect. We may come from different fields. What is common between us? One, we are all healthcare providers. Two, we all have an interest in medical education. Otherwise, you wouldn't be here attending this course. And three, we all share a wish to reduce the health-related suffering in our country. Whether the specialty that we belong to for this purpose of this course matters less. What's more important is our mission. And let us by no means underestimate what we are going to do together. If you, in your mind, have a thought that we are just going to through a course so that we can learn more, please let me add on something more to piggyback onto that agenda. Our mission is to reduce the suffering in our country, the health-related suffering in the country. And we have been handed an opportunity. You know how many years old palliative care in this country? 43, something like that? No, let me see. I'm not worse in mathematics than I thought I was. 36 years. More than 1/3 of a century. And we are still not walking. We are still crawling. We are still 37 years old toddlers. Less than 4% of the population has any access to any pain relief, meaningful pain relief, leave alone the whole of palliative care. If you take all aspects of palliative care, it's only a guesstimate, but less than 2% of our population is likely to have it. This is a sad state of affairs. And now we have been given an opportunity to get up from our crawling posture to stand up and walk and then run. And that opportunity comes in the form of inclusion of palliative care in curricula in 2 areas. One is the MBBS. Students who join the medical colleges in the year 2019 onwards are supposed to be learning palliative care. Nursing students who join nursing colleges from 2021 are supposed to have palliative care included in their curriculum. See what's going to happen? If we all work efficiently together, when my time comes, I have a reasonable chance when confronting a disease to still live with some comfort, with some dignity, and to die with some dignity. Less than 2% of our people have it now. And the power in this group is phenomenal. All medical teachers. And many of you would know a dozen times more than I about the science of education. Many of you would have gone through courses and learned the art and science of teaching and facilitating learning. So you and we will have together quite a bit of listening to do, a bit of learning as part of it, and a bit of teaching as part of it. Our knowledge areas, skill areas would be different. And we would all be educating one another during this course. But at the end, when the course is over, from that crawling position, we let it stand up and walk, learn to walk together and run. Then we will have the mission of not only teaching the students who come before us, but to facilitate educational programs in palliative care. We owe it to ourselves and to our family members to do this. This is not about someone else. Especially as doctors, sometimes we think about us, doctors as us, and patients as them, often forgetting that we are going to be them. This is about all of us. The Medical Council of India brought that change in, and now it's National Medical Commission. They, in the beginning, when they brought it in the 2017 and in the subsequent year, they did some training programs. Some of you might have attended some of them. Those training programs were specifically on 8-COM module, the module of attitude, ethics, and communication. They handpicked selected people from different medical colleges, zone-wise, sometimes state-wise, got them all together and did a training program that was typically about 3 days, sometimes a little more. They were taught how to teach attitude, ethics, and communication. That did not include pain management. That did not include end-of-life care. These are things which also now need to be taught. So, to repeat, we will discuss between us and learn from each other and teach one another about the various aspects of palliative care that are included in the curriculum. How they can be imparted. This is going to be tough. Everything else that the students learn in medical colleges, they see in the hospital, don't they? Medicine, surgery, obstetrics, pediatrics, everything. They see it. It's not only in the classroom, they see it being practiced in the wards. Unfortunately, of the 600 and something medical colleges in the country, in January this year, that was 590 something. Now, it must be something like 643 medical colleges in the country. Less than 40 of them would have palliative care programs. Out of the 640 plus medical colleges in the country, only a tiny minority have any form of palliative care. So, friends, we will be teaching something that they cannot see being practiced. This makes it tough for us. So, eventually, we are going to, your course may, after all the exchange of information that has gone in between the participants, may help us to impart that education. Some of the things that they cannot see being practiced will have to be imparted through videos, role plays, and so on. No other way right at the moment. The number of medical students in the country now come very close to 1 lakh. There is no way that 99,000 of them can actually see palliative care being practiced as part of their MBBS course. This is tough. I hope in addition to discussing what's included in the curriculum, we all will also be talking about how to make this actually a reality. Okay, before I close my opening remarks, I'll make one more point. So as we said, whether pharmacologists, pediatricians, oncologists, or anesthesiologists, or physiologists, or somebody else, we will all be together in the mission to facilitate palliative care education in the medical colleges that we have access to. This means that the physiology teacher may be teaching not only the things that are earmarked in the medical council's directive as to be taught in physiology, but any aspect of palliative care, because there may be nobody else in many medical colleges. You all are busy people. I don't think there will be anybody in this group who will be complaining that I do not have enough work to do. You all have more than enough to do. It's a question of prioritizing. This is a noble task. Imparting training to medical students and nursing students about how to relieve suffering is one of the noblest things that we can think of. And unmindful of which specialty we belong to, I strongly believe now that we are exposed to this field, we have the ethical responsibility to facilitate it wherever possible. That may be not only in your medical college. The National Medical Commission's regulations permit the appointment of adjunct faculty in any medical college. somebody working outside the medical college can be accommodated as adjunct faculty by any medical college. Sometimes they may pay, sometimes they may not. But if there is an opportunity to teach a group of medical students anywhere, if it is somewhere within my reach, I would grab it. Opening their eyes to the world of pain, which now they keep closed. They have been taught, just as I was taught in the medical college more than half a century back, to keep my eyes closed to suffering, to look at only the disease, and then to walk away. We will be opening their eyes. And that, I hope, we will be able to do to as many people as possible. And I'm sure the candle that you light in that darkness of suffering will not only spread light around the candle, you will be inspiring others. Others will be coming and lighting their own candles from yours. It is something that is bound to happen and to spread. I also see a positive fallout of this. Apart from this noble task of imparting education, I see this course and the course that you have already undertaken, catalyzing palliative care services in many medical colleges. You yourself must have felt, we need this. And the oncologists must be feeling, we are only cancer patients getting it. Others need it. And we'll be gradually broadening our vision, our horizons, and many medical colleges will develop palliative care services. And I can assure you, for the majority, it will not be easy. That is a given. We cannot expect a major change to be easy. We will have challenges. Dr. Muninder, Kalandi, Indira, Anup, Devashish, each one of us will have to brace ourselves. There will be challenges. You will be laughed at. Crazy guy, why is he wasting time doing this? You will be ridiculed. You will be fought. And we, nevertheless, recognizing that we have a noble task, push forward, maybe slowly in the beginning, then gaining momentum, then gaining people to come and join the team, and then building an army against suffering. Sri, unless you shut me up now, I'll keep on talking more. But with your permission, I am staying on to listen to the deliberations till 4 o'clock. Friends, thank you very much for listening to me. Sri, thank you for facilitating this. Sri, thank you for making this happen.
Thank you, sir. Just maybe we can spend a few minutes if there are any questions or comments. I know that this was not a lecture to ask questions, but if you have anything to share from your side, we can spend 2 or 3 minutes for that. So if there are no questions, we can move on to next formal session. Thank you, sir, for setting the context for the program. Thank you so much for sharing the vision that we have when we started this program. So now we have a session on the principles of integration in education, and we have a very eminent faculty for delivering that session, Dr. Kadambari. Dr. Kadambari is a professor in the Department of Surgery, JIPMER, Puducherry, And she's specializing in breast oncology and breast surgery. And she's also a member of core group of resource persons at NTTC training program at JIPMER. Sir, I met Dr. Kadambari a few weeks back when I went to JIPMER. I was absconding from work for a week. And along with a lot of learning that I had from there, this was one thing I thought is very essential for all of us to understand and to understand before we are onto this mission of integration. So we thought, as I mentioned in the beginning, we use that word a lot, but then I realized that it's a lot of things beyond that word integration. So I wanted ma'am, and she readily agreed to come and help us for this session. And thank you so much, ma'am, for agreeing to be a part of this program.
Thank you, Dr. Sridevi. Thank you for this opportunity. Actually, it's an honor to be associated with your program because this is truly one area where we need to talk about integration, because this is essentially what integration is all about. So so good afternoon, sir, Dr. Rajagopal. Nice to meet you. And I think we met once when you had visited JIPMER a few years ago.
Yes, ma'am.
Yeah. So nice to meet all of you. And I'm happy to see that there are so many, faculty who are interested in this topic of palliative care and how to teach students in MBBS. Of course, as Dr. Rajagopal has pointed out, it is not just the MBBS students, but it's also the postgraduates who need to be exposed to palliative care, because they are the ones who are actually practicing the profession and dealing with patients directly. So shall I jump into the session, Dr. Sridevi?
Yes, ma'am, please.
Okay. So over the next about 45 to 50 minutes, I will take you through the principles of integration and how it is applicable to us as medical teachers and how do we go about it. Because this is the buzzword now in the present CBME curriculum. A lot of emphasis is given to integration. So many of us are still grappling with the concept and how to actually implement it. So just to introduce you to the origin of the term, it is derived from the Latin term integrationem, which refers to actually the wholeness, and wholeness being more than its parts. So it is something which is a coming together of parts to create a larger whole. So if you look at the life of a doctor, a day in the life of a doctor, there are so many activities that we do as doctors. We diagnose, we prescribe, we give the treatment, perform surgical procedures, and in addition, we also have to stay current on advances in our respective fields. And the final, last but not the least, is the service orientation. We are here to relieve suffering. We are here to help humanity, and that is a major commitment from our side. So if you look at medical practice itself, integration is putting together all these different aspects of our practice. So it is a core essential element of medical practice itself. So it is there all around us. But as teachers, what do we need to understand about integration? What we need is to understand what is integration and how it occurs. And how are we going to make sure that we enable students to integrate information or their learning? So I welcome some thoughts from you. You can just put it in the chat box. What do you think integration is? What do we mean when we use the term integration? When we talk about education or medical education? Am I audible to everybody?
Yes, ma'am, you are.
Okay.
We are awaiting response from the participants now.
Yeah. I think most radiotherapy teachers will not have access to undergraduate or for a very short duration of time. Am I right? They take very few classes for undergraduate students. They are most involved in post PGs and in general, what do you mean when we talk? Yes.
There are few chat which has come up.
Oh, sorry, I'm not able to see the chat.
I can read it for you, ma'am, if you.
Yes, coordination with other departments, horizontal and vertical integration, coordinate and collaborate. Okay. Okay. So basically, when we talk about integration, it means a synthesis of knowledge. When we talk about integration, what we are trying to achieve in the student is knowledge synthesis. That means putting together information and making connections which result in the result in new knowledge and understanding. So that is what we mean by integration. And therefore, it is not wrong to say that integration occurs in the mind of the learner, right? Are you okay with me on this? That it happens actually within the learner. Integration is happening inside the learner and not necessarily just in what we teach. So if you look at the MBBS student or an undergraduate curriculum or medical education, the student is, subject to information from so many different sources. They have different subjects, they have different phases of learning, they have different experiences in the classroom, in the clinic, in the outpatient, in the operating theater. So many inputs coming into the student and having to work hard on all these different subjects and then make all the connections between these subjects and between all these experiences so that they become capable of traversing this complex path of medical practice. So in undergraduate medical education, integration means an ability to connect and interrelate knowledge from different sources. So it's not just integrating basic science and clinical sciences. There are a whole lot of experiences and a whole lot of resources from which they gain these experiences. So there can be factual information in the classroom, experiential learning, which happens by the bedside, in the laboratory, and so many in the community. And they put together all these experiences and the knowledge they gain from these experiences in a way that fosters understanding and performance of the professional activities of medicine. So integration is much more than simply connecting basic and clinical sciences, which is the common understanding of integration. So therefore, integration can be seen in three ways. The main thing is the educational outcome. The educational outcome, which means integration of learning. It can be seen as a learning process, which includes knowledge and memory integration. And it can be seen as the educational practices which are required to achieve the outcome. And one of them is curriculum integration. So we look at integration from these three lenses, looking at it as a learning outcome. Integration of learning refers to a higher order learning. And as I said earlier, learner moves from basic understanding to more abstract conceptualization, which is what happens as we move from undergraduate to postgraduate, or within undergraduate from first year to internship. And this happens because they build on knowledge of isolated facts to develop ideas in new and different ways. So this is what we mean when we use the term integration of learning. And this is the educational outcome that we are trying to achieve. So this is important because meaningful learning will happen only when this kind of knowledge integration or learning integration happens. And if they don't integrate information from different sources and the experiences that they have at different times and in different situations, they cannot build the domain of medical knowledge, which is required for their practice as a doctor. So looking at it from the second lens, that is through the second lens as a learning process, knowledge integration is required for integration of learning to occur. Basically, it's a mental process. It's a cognitive process through which the learner puts all these different experiences together, sorts them out, finds the relationships between them, and finds frameworks for connecting them. So it's a cognitive process, knowledge integration. So, for example, in undergraduate medical education, making the connections within a subject, for example, in physiology, studying the cardiovascular and respiratory system. So making connections, how they are linked, various systems, how the renal system is linked with the cardiac system. So making connections within and between different subject domains. So it could be between anatomy and physiology, between anatomy and surgery, between physiology and pharmacology, pharmacology and medicine, and so on. So knowledge integration is constantly happening in undergraduate medical education. Now, actually, integration is not something which is peculiar to adults or higher education. It happens naturally in children as young as 4 years of age. So by that age, they are able to put together all their different experiences, separate experiences, and gather and develop a new understanding. And as they grow to the age of 6, they become even less dependent on the teacher and are able to, because they have faster processing of information, and they are able to independently put together the knowledge which they gain from various sources. So in what I'm trying to point out here is that integration of knowledge and information is a natural learning process of every human being. So for integration of knowledge to occur, there has to be a vast knowledge base. And for a knowledge base to be built or constructed, memory integration is a fundamental process. Before we go to memory integration, please stop me if I'm going too fast. I know this is a little bit of theory, but it's necessary for us to understand this before we talk about what are the strategies that we can use. Please don't hesitate to stop me. Dr. Sridevi, you keep monitoring the chat box, please.
Sure, ma'am, sure.
Okay. So before we go to memory integration, we'll just have a look at what we mean by learning. How does learning occur? Primarily, learning means we go through several experiences, right? Visual experiences, auditory experiences, and so many other experiences. Now, these experiences are represented, or they are stored, not stored, I would say, they are represented in the brain in the various domains of the brain by a process which is called encoding. So these representations which develop at the time that the person is undergoing these experiences are fortified or strengthened during sleep. And this process is known as consolidation. So that's how learning occurs and memory develops. So this phase of learning or information storage, information gathering, and memory building is known as, represents the storage function or storage step. Now, in order to strengthen this still further, you have to retrieve that knowledge. You have to recollect and bring it out of your storage. And that is what happens when we conduct assessments. When we ask them questions, they bring back their knowledge from memory. So for learning to occur, both storage and retrieval are important. And if we know this, these are the educational strategies that we need to implement. So for memory integration, if we take, basically memory integration has 3 ideas or 3 concepts. The first is reactivation of prior knowledge during learning of new information. So if prior knowledge is reactivated, if a student, when he is recording new information or reading new information, recollects what he has studied earlier, that results in a stronger association and forming of stronger knowledge networks. So we can call this a study strategy. The second concept is, if information is given to a student which already has a pre-existing association, then it reactivates memory, and again, it strengthens the memory for that information, right? So for this can be taken as a teaching strategy. For example, I'm a clinical teacher, I teach surgery. So when I take a class in, for example, breast cancer, I would, if I keep going back into the anatomy, the physiology, the pathology, and what they have already learned, and make connections with the clinical signs and symptoms, then it creates a reactivation of previously learned information, and therefore they are able to make the connections. So this is a teaching strategy. And finally, as I said, retrieval is an important step in in memory building. So actively reactivating previously learned information when studying new information is beneficial for subsequent memory. So this can be taken as both a teaching strategy and an assessment strategy. So as a teaching strategy in a class, for example, you can ask questions of students from previously learned information. So you can ask them, what have you studied about? Can one of you describe the anatomy of the stomach? What is the lymphatic drainage of the stomach? They've already studied that in anatomy. So if they recollect that information, and then you explain to them what is the principles of lymphatic dissection when we operate on malignancy of the stomach, then it makes sense to them. And that knowledge and that connection gets fortified and strengthened. So these are three strategies which we can employ when to address memory integration. So coming to the crux of this presentation, what are we seeking? The answers. As teachers, these are some of the questions we have. Why is integration needed? What needs to be integrated? When should it occur? Where should it occur? And how can it be promoted or scaffolded? So we'll take these questions one by one. Why is integration needed? Can I have some quick answers to this question? Why do you think integration is needed?
Anyone would like to unmute, or you can type in the chat, I can read.
To convert information into knowledge, make learning more effective. Okay. Yes, I particularly like that, because making learning more effective and more interesting. Yes, to better understand concepts and implementation, to facilitate deeper learning. Fantastic. So better patient care, to have more complete learning. Very nice. Ensures that all systems work together, comprehensive learning. Okay, right. So basically, as just to give you an example which always occurs to us when we use the term integration, is this thing, making connections between basic and clinical sciences, right? That's the first thing that strikes us when we think about integration. So all of you will agree with me that this is a core aspect of undergraduate medical education. And why do we need this? Because they need to understand clinical signs and symptoms. It helps them if they already know the anatomical basis of a sign or a symptom. Therefore, they are able to relate clinical features to mechanisms of the disease in the pathology and microbiology and so on. For diagnostic reasoning, helps them to make diagnosis and differential diagnosis, and for solving difficult diagnostic problems. Okay, so these are some of the reasons why we need them to integrate basic and clinical sciences. Another quick question to you. Do clinicians routinely use their knowledge of basic sciences to make a diagnosis? Most of you are clinicians, but this can be answered by the basic scientists as well. Can I have some responses? Just a yes or no will do. Sorry. Yes, yes, yes. Okay, the key word here is routinely. Do you think routinely use? Not always. Okay, that's nice. Okay, so the answer is somewhere in between. Maybe not always is the right answer. Actually, it depends on the level of the learner, right? So a novice learner, if you see an MBBS student or an intern, they will use analytical reasoning, making the conscious connection between their knowledge of basic sciences and clinical sciences to make diagnosis. But when it comes to experts, they use what is known as non-analytical reasoning, right? Some of them call it intuitive, but it's not actually intuitive. It's definitely a cognitive process because they have already encapsulated their basic science knowledge and they have formed what are known as illness scripts with their experience as they see different presentations of the clinical case. This is stored, represented in their memory and consolidated, and they keep retrieving it in a given situation. So they are able to make a shortcut and reach that diagnosis much earlier than the undergraduate or a more novice learner. But even experts have an exception. In a difficult or uncertain situation, they do go back into their knowledge of basic sciences in order to make a diagnosis, right? So there are a whole lot of reasons why integration is important. Complex problems, higher order thinking, looking at real world problems, interest in learning and excitement, reinforcement of important topics, and retention of learning. We looked at how integration improves memory retention. Right. Coming to the next question, what should be integrated and when? Any answers to this? Quick answers? Let's start with what should be integrated. Apart from basic and clinical sciences, that is an obvious thing, but what else should be integrated? Knowledge, experience, self and others, applied knowledge. Okay. Right. What connections should they make? What connections should the learner make? Right from first year preclinical exposure in the form of case-based scenarios, different strategies. Okay, that we'll come to in a bit. We'll talk about the strategies which we need to employ as teachers. So basically, we need them to integrate these three core aspects of learning: content knowledge, skill development, and attitude, right? You know the three domains of learning: knowledge, skills, and attitudes. Basically, in addition to what we are talking about, basic and clinical sciences is content knowledge, to some extent skill development. They also have this important element of attitude, right? So we want them to learn the right attitude. And in this particular course that you're going through, attitude is a major element because they have to, unless they have that attitude of wanting to help. Dr. Rajagopal just now mentioned that they have to open their eyes, which is actually the step of integrating. We have to bring in that attitude towards a patient who's suffering and who's in pain. Right. When should it occur? It can occur during a semester, during the same year, amongst during the same phase of MBBS. It can occur across phases, and basically both horizontal and vertical integration. Essentially, throughout the MBBS training, we have to keep focusing on integration, whether it's knowledge integration, skill integration, or attitude integration. So this is the reason, because in medicine, they have to integrate basic science, which is knowledge, the applied skills of the profession, which is the clinical skills, knowledge gained from prior experiences or experiential learning, and these two aspects which are very important with respect to attitudes. So all these are essential components of the learning of an MBBS graduate. So where can it be implemented? There is no single area where it should be done. It should be done in all the settings where learning teaching occurs. In the classroom, at the simulation center, at the bedside, in the community, and in interprofessional learning environments. Okay, anyone thinks otherwise? Anybody has any other thoughts on this? You can unmute yourself and speak if you find that easier. Any questions or any contradictory ideas? Okay, so then we'll move on. Right, now coming to the main part of this session, how can we scaffold integration? We are all teachers, we are teaching undergraduates, postgraduates, but how can we ensure that integration is actually happening? Now, this requires us to employ some educational strategies. And for this, you have both the learner aspect and what the teacher needs to be doing. So the learner, as I said, a knowledge base is very important for integration to occur. So the learner has to employ effective learning strategies. He has to make sure that he builds that knowledge base. And as a teacher, our involvement is in teaching and in assessing and making the arrangements in the curriculum or designing the curriculum in such a way that integration is fostered. So this is the role of the learner. He has to create the knowledge base and make sure that he employs effective learning techniques. Now, can I have some of your experiences, what you do as a medical teacher to support integration? I understand that you're not, many of you are not involved in undergraduate education, but how do you do it in postgraduates? You can share some of your experiences.
It will be good to listen to some voice. If you
Yes.
can unmute and talk, that will be good for everyone.
Yes, please. Yes.
I would like to add, ma'am.
Yes.
Actually, we organize a session in which different people from different departments, they give their views on the single topic. Say, for example, on tuberculosis. So we will discuss the basic diagnostic modalities, then what are the pharmacological treatments available, what are the presentation of tuberculosis, and how the categories of tuberculosis are divided. So different people from different departments, they integrate to teach tuberculosis as a whole.
Okay. All right. Any other experiences? This is a very common way that integration is fostered. Any other experiences? Right. Okay. So you're from pharmacology, isn't it, Dr. Shivani? Yeah. So now my point that I would like to make here is It is.
Sorry to interrupt, Dr. Neelkant is asking, he wants to share something.
Oh, sure, please.
Dr. Neelkant, can you unmute yourself, please?
I want to share what allow me for that.
Please go ahead.
Only the host can share in this meeting, so I
Oh,
cannot
you want to share a
photo.
document? Okay.
A JPG file.
Okay. I am not sure.
Can it
how.
be possible?
Just give us a moment. We'll enable. Yeah, now you can do.
Okay, thank you. I cannot share while the other participant is sharing. So
we stopped.
Okay, I'll stop the share. Yeah.
Stopped it from our side. You can try now. Is it possible now? Yeah.
everybody can see?
Yes. Correlative thinking. Okay.
How to integrate things? First, I wrote all the names, and then I asked the students to correlate each and everything. And they answer all the things, and after that, this whole picture is like this. The integration is the number one includes all the things. I didn't know the name integration, so I wrote correlating.
What is the topic you are teaching here?
I was teaching surgery in sign and symptomatology, but I was trying to teach them the need of correlation and need of integration. What is the importance of integration? And this is like their brainstorming activity to stimulate their brains on this integration. And so I had this idea to give them this exercise, and I did that exercise.
So can you just explain how you did this? Because there are some, if I can see here, there's something about driving, doctor, petrol, traffic, scooter.
This is my own experience. This is me actually. I was driving my scooter and with I am doctor with driving petrol, and how traffic is integrated. I was driving with music on with JBL speaker.
Oh, okay.
With JBL, there is linked with spread of happiness. I was happy while listening to music. Because I had to listen to music, I have to drive slowly because the noise of driving will obscure my music. So I was driving slowly. So there was safety with less speed of driving also, and less use of petrol. And with slow driving, I was hitting my both legs for it was like for rhythm. So my both lower limbs were exercising while the whole driving. Because my ears were just listening to music. I have to, for safe driving, I have to be more focused on my visual things while driving. So focus was more. Music is thus integrated ear protection. Yes. While driving, I cannot use earphones because it will mask all other noises. It was a big speaker, Bluetooth speaker, medium size, and it was held in between on the scooter. So I can hear all the things. Preferably, I was hearing music, and the music was regarding Shivji. On some Shiv songs were there, so it was linked. I wrote that thing.
Right. Okay, so
children don't know this story, but they try to correlate each and everything with their own answers. I don't know what they answered, but they correlate the things.
Yeah.
Okay. Then after that, I really revealed that this is my own experience.
Thank you, Dr.
Thank you for sharing that experience, and that's a nice example of kind of explaining what integration is all about. Okay.
Yes. Thank you for allowing me to share.
So when we look at the role of a teacher, as I said, there are teaching strategies, there are assessment strategies, and the curriculum arrangements. This is where we step in as teachers. So some of the teaching strategies which we can employ is go into depth of the subject. Now, this might seem a little contradictory to what you commonly read in literature, that we look at more of breadth than depth in undergraduate medical education. But that is not completely true. For some concepts to develop, some amount of depth has to be ensured. And it's up to us as teachers to judge which are the areas where we really need them to go deep into the concept building, and where we can just leave it superficial. For example, in my undergraduate teaching, my teachers were very clear. As an undergraduate, it is sufficient if you know this much. So it was clear to me that beyond this is an optional thing. If I want to understand more, I go deeper into it. But for my curricular, for my completion of the course and for my graduating as an MBBS student, if I know this much of whether it's anatomy, physiology, pharmacology, that much is enough. So we as teachers should decide how deep into the subject they need to go. But depth is important. The second thing is time. We have to give them adequate time to make those connections, right? We have to devote adequate instructional time to make those connections. The third is what is known as desirable difficulties. I'll come to that in a minute. There's no, I don't think I have time to go into each of these techniques, but if you want to learn more about this, you can just Google science of learning. And there is a lot of information on science of learning and study strategies which are required for more effective learning. And some of them are spacing, interleaving, and practice testing. Practice testing is very simple, as its name suggests. You keep giving them repeated assessments, but not necessarily to mark them or give them scores, but for them to understand and build the connections. So practice testing, what is commonly called formative assessment. So these are some of the teaching strategies. Then you design your assessments to test integration. Train your learners in effective learning techniques. They may not all be knowing what are the ways. Many of them face difficulties when they are faced with so many subjects and such extensive content that they have to master in 5 years' time. So we can train them in effective learning techniques. And finally is the curriculum arrangements. So when we are teaching for integration, in all our classes, whether we are a basic science teacher or a clinician teacher, we have to help them continually make connections. In our classes, we need to keep making connections between concepts, principles, between the various settings where learning occurs. In my classroom, I should also talk about what they would see in the community. In the community, they should be talking about theory and connecting theory with what they are actually seeing in practice. That is integration. This is what is desirable difficulty. By this term, it means that you don't provide all the information or everything to them in your classroom or in your be it a lecture or a bedside discussion. Give them some challenges. Provide them with some challenges which will tickle their brains sufficiently that they go and try to find out answers. And that is a strong motivation for them to learn. In our own college, actually, we had taken an informal feedback from students about lectures, with what they feel about the kind of lectures. Two important things they mentioned. One, don't use PowerPoint. And two, don't give us all the information. Leave something for us to read on our own. So students want that actually. So provide them with some challenges for them to. So these difficulties, you can ask them a question, go and find out the answer, give them an assignment, a homework. That will trigger more interest and make the help them to learn and also for long-term retention. And for assessments, very often we don't know how to design our assessments such that it tests their capacity to integrate. So one simple example, you can use MCQs. Use an MCQ item followed by a question on asking them to explain why they chose that particular answer. Give the reasoning behind it, right? So that is one simple example. So basically, assessment does what is known as has what is known as a testing effect. So repeated it's good to have frequent assessments because it contributes to that retrieval component of knowledge building. So these are the this is how assessment triggers or helps to retrieve memory, and it all depends upon the cues, right? The memory retrieval depends upon the cue that you provide, where the cues are available, and the way the learner will retrieve knowledge and skills will vary with the cues. So basically, it depends upon the questions we ask, how we design our questions, how we frame our questions in order to help them to retrieve knowledge from their memory. So you must have heard about Bloom's taxonomy. There are various levels of knowledge, starting from memory and going up to synthesis of new information. So our questions should be targeted at what are known as higher levels of Bloom taxonomy, from understanding, application, rather than just testing their memory by asking them recall questions that will simply ask them to recall information from their memory. The last strategy is curriculum arrangements. There are many ways in which integration can happen. There is this famous conversion of H to Z. This is known as the spiral curriculum. This is where horizontal and vertical integration is a model of horizontal and vertical integration. And this is the very famous ladder, or called the integration ladder, which was described by Harden in 2000. Basically, at the lower levels of the ladder, you have isolated departments teaching subjects differently. And as you go up the ladder, these boundaries between subject disciplines gets blurred. And finally, at the top, you don't have anatomy, physiology, medicine, surgery, but you have, and it's not even systems, it's more like, for example, metabolism or pathophysiology, things like that. So that's an integrated curriculum where the subject matters, the lines across between subject matters are broken and blurred. So this is an example of an integrated curriculum. As you can see, there are no subject matters, subject disciplines as such. It's more of an integrated experience which is provided to the students across the 4 years of the integrated, of the undergraduate curriculum. But one thing we must remember, that simply arranging curriculum as horizontal and vertical, for example, the example that we just heard, that they call teachers from different disciplines to come and talk about a subject, that alone may not be enough to produce integration of learning. So what we need is a curriculum where the knowledge is slowly expanded and previously learned information is often revisited to allow knowledge networks to form. So there are many challenges. It's not easy. First and foremost, lack of will, lack of good leadership support, inadequate infrastructure, prefixed mindsets. We all think our own discipline is the most important and we cannot, step down to involving others. We feel that it will cause more workload for us. And there are many myths. And this is one myth, that multiple teachers will be required for one integrated session. It's not required because it's a big headache to bring in. I don't know, Dr. Shivani, whether it has been your experience. Many times it's difficult to coordinate and arrange for these so-called integrated sessions because somebody will be busy, they will not have time. The other thing is, if you call a pathologist to talk about a topic, he will talk everything in that topic. He will not tailor it to, to suit the level of the learner. He will, and each one thinks that their subject is important. So for an undergraduate curriculum, what we need to do is sit down together and have a conversation. If I want to incorporate some anatomical content in my lecture, I talk to the anatomists and ask them, what do you teach in anatomy and what are the important things that in anatomy that they should understand or remember, and then reinforce. An anatomist can ask me as a surgeon, what is the importance of this in surgery? Why should they know this knowledge for surgical practice? So these conversations are more important than calling different teachers from different departments to conduct an integrated session. So the first step is to train teachers in how to conduct these integrated, or rather on the idea of integration, assign responsibilities, develop modules or sessions, design integrated assessments without which helping them to integrate is of no use. You can have teaching modules which develop integration, but then if you don't assess them in a similar way, it's of no use. And finally, you deliver the curriculum. So my take-home messages are: integration occurs in the mind of the learner. It is the desired outcome of learning, of education. Knowledge integration is an automatic process that begins in childhood. A knowledge base is central to integration of learning. Memory integration is required for a knowledge base. Teaching includes curricular depth, instruction time, and desirable difficulties. Assessment scaffold integration by employing retrieval practice or the testing effect. Curriculum arrangements themselves do not result in integration of learning. Thank you very much for your patient listening, and I can answer a few questions if you have any.
Thank you so much, ma'am. Ma'am, can you go back to the slide on challenges?
Yeah,
I just wanted to ask them whether they face these challenges if people are or have already started teaching or integrating many, not just palliative care. And if so, how do they plan to, because now we are here to integrate palliative care. So if they feel these challenges are real, how are they planning to overcome those challenges? Maybe 1 or 2 points from the participants. Ma'am, can you project that slide on challenges so that
this is the one, no? Oh, sorry, I stopped sharing.
Yes.
Okay. Sorry. Something is wrong. Yeah. Is it visible now?
Yes, it's visible. So I would like to ask the participants, because now you are all planning to teach medical students or integrate the lessons that we learned during the last month or so. So just wanted to hear from you, how do you plan to tackle these challenges? I'm sure most of you might be facing these challenges. So if so, how do you plan to overcome these? Along with other questions to ma'am. I'm just curious to know about this. That's why I focused on. Anyone would like to unmute?
Do you agree with me on all these challenges? Do you face them? Or, I mean, these are not comprehensive. There may be many other challenges which are peculiar to your context. These are the common ones.
Yeah, there are lack of staff. So working with 40% faculty. So but he says he wants to teach, so I will. So I think lack of enough faculty members, especially new institutions, will be a challenge.
Yes. My response to that would be, like I said from the beginning, all of us are teaching undergraduates. All of us have been through the undergraduate course. And we decide how much an undergraduate needs to learn in our particular specialty. Okay, that's point one. The second thing is, the best way to integrate, in my opinion, is to make those connections when you are teaching them in your class. So if it is a bedside discussion, for example, talk to them about end-of-life care issues, right? If you're a community medicine teacher, take them to a center like Pallium, where they are doing work like this. So they see, they have an idea, okay, there are patients like this who need our support and who need, so that develops their affective component. They realize that being a doctor doesn't necessarily mean just, you know, operating or prescribing medicines. It also requires a more, what shall I say, empathetic approach to patient care. A simple example, my husband is a physician, right? And recently he had a tooth problem for which he was prescribed antibiotics. And when he took the first 2 doses of the antibiotic, he realized what severe side effect he was having. So he stopped the antibiotics halfway. So it's unless they experience that, they don't understand. And then we see patients who have stopped their medications halfway, we scold them. We say, no, how will it be effective if you don't take the full course of antibiotics? So unless we actually give them that exposure and that experience of talking to patients who are having what shall I say, metastatic malignancy or severe pain or whatever this situation, they can actually see for themselves and learn the pain and the situation that that patient is in. So we need to provide that learning experience. And if we can focus on this and public health, these are 2 areas where our undergraduate education lacks. And that is why many students don't opt for these kind of specialties, because they don't understand the importance. Today, I understand the importance of public health, but it's too late. So we need to expose them to these, not just in the community, even in our classroom. Give them a case scenario and ask them what you would do. So we can do it within our own classes. It's not necessary that you should have separate faculty devoted to teaching palliative medicine. All of us are clinicians. We all deal with end-of-life care situations. So we can incorporate that in our teaching.
Thank you, ma'am. I'll wait for some comments in the chat. I myself have 100 questions by now, so I'm keeping quiet for some time. So we would like to hear from you if you have any questions. Yes, Dr. Sharani, please.
Actually, we have first years are having family adoption program in community medicine. So we have started doing. So I think it's a good opportunity to add on, because we have gone to many families, because it's the starting first time we are doing it. And we saw many people who require palliative care who couldn't come across. So like Saturday only we had gone. So we need some inputs to however to go about, because we are not that much here, so much associated with palliative care here in Tupkur. So I just wanted the inputs, like what should I do and how should we go about? Because we are getting opportunity, because we are in teaching aspect, actually students, first year students are getting more exposed because of family adoption program. Because all these years we used to only teach about nutrition, how to assist, but right now they are doing it at the very basic. So it was actually good part which was started, we thought it.
Right. Yeah. So this is exactly what I was saying. But then our curriculum this family medicine or family health, whatever you call it, that program stops at the 7th semester, right? When they come to final year, they're completely out of touch with community. And that is where they lose contact. So they think in final year, it's only necessary for them to study medicine, surgery, OG, and pediatrics and pass the exam. And by the time they reach internship, most of them have, and then they start focusing on PG and this, that. So they lose touch with community care. So there has to be some way in that. That is why I said maybe our curriculum is structured in such a way that we can't provide that. I don't see any reason why there should not be a community medicine in the final year. We should have community medicine in final year as well, because that is when they are actually learning the entire core medicine, surgery, and OG. And a lot of it is practiced in the community. Okay, that's one side of it. But the next best we can do is, for example, in my class, I take classes on breast cancer. I could give them situations. I could give them a case scenario or show them some pictures, or even take them to our regional cancer center and talk to patients who are having metastatic breast cancer and who are on palliative care. And like I said, in first year, they are still not very cognizant of the science behind it, right? But when they come to final year, they've already been exposed to pain care. They know what medications to prescribe, what can be given. They know what surgery can be done. And so they can correlate their clinical experience with, so the first year is to lay the foundation. And this experience should be there right till they finish final year or during internship as well.
Thank you, ma'am. If I can add on to Dr. Usha Rani's question, I think that's the family adoption program is the best way to convey the total suffering that the patient and the family as a unit will go through, right? You have listened to the introduction to palliative care. So that rather than just listening over a lecture, they're actually seeing the patient and how the family is sleepless and the nights, how the family go through the burden of caregiving, how the children cope with the illness in the family. Everything is seen by them in the community. So you can give them a task to talk to the patient and the family, maybe one group talking to the patient, other group talking to the family, and come back and tell you what did they observe, what all problems they are going through. As ma'am said, they are not into the core medical subjects yet. So they have fresh eyes. They will see suffering. They'll see that, oh, I heard that the wife is not sleeping, or the wife is tired of looking after this patient. So they are learning it not from a PPT or from a textbook, but they are actually learning it from your community family adoption program. Just touching up, you have one session on serious health-related suffering and various methodologies to teach SHS. So probably we'll cover a little bit on that. But that's the best opportunity, I must say, to understand what the patient and the family go through in actual scenario in the community at their home. Are there any other questions? We are just overshooting time, so we would like to finish the sessions on, oh no, we have 2 more minutes. So if we have some more questions, maybe one or two more max. Maybe towards the end of this, we'll be going through the challenges and how to tackle those challenges again in the end of this week. So there is a comment from Dr. Kalindi telling, during clinics, the focus is primarily on diagnosis and management of new patients. Patients on palliative care are rarely discussed.
True. This need not be discussed with every patient that we are talking about. But we should introduce this idea into them, that there are situations, see, generally students, what I see in final year, this is not an exam case. So I don't want to take this case. No, we have to tell them that MBBS is not simply about passing the exam. They also need to see the variety of cases, the kind of patients whom they are actually going to deal with in during their practice. So once in a way, during a posting, we can have a situation of, showing them a patient who needs this kind of care.
Thank you, Dr. Kalindi, for bringing in that point. Maybe if there are no other questions, or you can keep sending your questions to us in the WhatsApp group or through emails. We'll discuss that in the coming sessions. Thank you so much, ma'am, for taking us through the session. And this is a very new topic for most of us. Probably, as Dr. Rajagopal mentioned, many of them are involved in teaching, but some of them may not be involved in undergraduate teaching. But this is a very important topic before we go on to the next topics in this program. Thank you so much for spending your time with us.
Thank you. Thanks for the opportunity. I enjoyed it. Thank you very much. Thank you, sir, Dr. Rajagopal. Thank you.
So thank you all the participants. So just a few points for the coming sessions for class 4 sessions. The coming sessions will be mostly small group works. So it's very important that you be with your group. You can't just attend the session for 20 minutes or 15 minutes and go out, because the group work will be happening in the small groups. So you have to be with your group and then come back and share your learnings in the coming days. So it's very important that you continue to participate. Otherwise, this is not going to work in a way that we really want to, because we have spent 20 sessions to integrate this whole thing. So this is just 4 more sessions for all of us. To be with the group, get to know your group member. We have already circulated the group division and everything in the WhatsApp group. So just get to know, because you will be given activities which is to be done in the group during the session. So please make sure that you are there for the entire session from beginning to end in the coming days. Thank you so much for today's participation.
Thank you, Dr. Sridevi. So we will see you tomorrow with the continuation of the faculty development program. Till then, this is Sripriya, along with Dr. Kadambari and Dr. Sridevi signing off from the TIPSECHO Hub. See you tomorrow again. Bye-bye.